Hello, everyone. We would like to start session 3, ovarian tissue transplantation. The Professor Catherine Poirot and Dr. Koichi Kiyono will be the host. I will host the first speaker, Klaus, and the second speaker, Yana. And Catherine, host Koichi Kiyono, and moderate the last discussion at the end. So I would like, each speaker talk will be give 20 minutes lecture and followed by 20 minutes discussion at the end. So I'd like to start this session, and please, Klaus Anderson, start. Before I introduce the Professor Anderson, he is a Professor of Emeritus of Human Reproductive Physiology, Faculty of Health and Medical Science, University of Copenhagen, Edinburgh. He has headed a national program of cryopreservation of human ovarian and testicular tissue, and is considered one of the pioneers in the field. Please start.
Thank you very much for this kind introduction, and thank you very much for inviting me here to Japan, to revisit Japan. It's an absolute pleasure to be here, and the organization is, as usual, absolutely on time, and everything is organized, so that's very nice. Thank you very much. I've actually been asked to talk about a subject which is not really new, in the sense that we have done this for many, many years now, and I would be happy to share with you the experiences that we have with that. And as you have been, if you have been to the other room, room 2, and you have heard IVM, we have had serious discussion on how IVM may actually impact on the results when you transport the ovarian tissue. But I would like to take this right from the beginning, and then let's go through and see what the different aspects is of this. So, everybody hear me? Good. All right. So, here we go. Forward. So the outline would be what is actually the point of doing this, and what is the practical considerations? How do you do this? How do you implement this in clinical practice? And then from the point of the patient, the point of the referral center, and the central laboratory, these are the 3 key players in getting this all to work in a nice way. And there's different aspects from each of these 3 participants. And let's have a look at how this actually works, and whether this is working in real life and we are getting children out of this. And then at the last point I want to mention for you is that it's not entirely, it's actually very important which kind of media that you decide to transport the ovarian tissue in, and there we have done some studies on that. So here we go. So the idea, on the right-hand side, you can see that egg transportation is a delicate matter. This is something which has been done for some time now, but this needs a lot of planning, and it's not quite easy. But the idea of doing ovarian tissue transplantation, of course, is that this is not a procedure that is so often used. This is not IVF, where we do many aspirations a day. There may be 1 or 2 a week, and there it may be advantageous to actually take the ovary and put into a central laboratory which has the expertise on doing this and is focused on doing that. So the idea is that the woman is now having her treatment for a cancer at the local hospital. So she don't move. She's actually being looked at the doctors in the local hospitals who are counseling her, saying you may need fertility preservation. If she agrees to this, the operation is done at the local hospital. It's surgically removed there. It's a small operation. Often, in our cases, they do this in the morning. They do this in 15 minutes, basically. Then it's transported to a central laboratory. In our case, we do the procurement and the cryopreservation of the tissue. And then if the patient later on comes back and say, you know, 5 years ago you froze my tissue, can I have it back? She stays at the local hospital. And then the tissue is transported in liquid nitrogen to the local hospital where thawing is done and the operation is done. So this is the principle of this. And you can see this is Denmark. And if you look here at the insert, this is Europe. The little red dot up there, this is Denmark. And the news yesterday was, are you prepared for snow? So we are it's becoming winter in our country. But we are now actually having 4 centers from which we receive ovarian tissue for freezing. So I'm located in Copenhagen. So we receive tissue from the university hospitals in Denmark. This is Aarhus and this is Odense. So the tissue is transported to us in a bag like this. This is basically just a sterile 50 ml container where you have a transport medium and then we use ice. The ovary is immersed in here. Often we cut the ovary into 2 halves. It's perhaps not too necessary, but this is at least the way we do it. So the procedure is that the operation is planned to be performed around 8 o'clock. So first thing in the morning, they do the operation for taking out the ovary. It's cut into 2 halves. It's picked up at a person coming to transport either the ovary directly in a car to Copenhagen, or initially we actually did it in a plane, and then we had these aluminum containers where we did put in the tube, because you cannot put anything on a plane unless it's going through X radiation, and we didn't want any radiation to the ovary. And then we had a domestic flight taking it to Copenhagen, somebody to pick it up, and it arrived with us around 1 o'clock, so 4, 5, 6 hours later. And this is, of course, because Denmark is so small, we can do that. In the next presentation you hear from Germany, it is overnight. But this is the practical aspects, and you see the box here. It's absolutely straightforward. This is a flamingo box that you receive almost any chemical that you buy, which is on cooling. You will receive it in a box like this. We just take any box like this, we put in crushed ice, and then put in the ovary in there. The beauty of crushed ice is that it's defined by being 0 degrees. So the ovary is cooled off to 0 degrees, and this is the only quality assurance we have on that is when we open the box, we need to see ice in there. And we have never ever been in a situation where there was no ice. So it's always just been transported at 0 degrees. So if we look at it, you know, there's a lot of delicate considerations here to do egg transportation. So, you know, you can do this in different ways, and of course you have to take a lot of stuff into consideration and develop this over the years, and we have done that. But let's look at the 3 parties involved in this. First of all, the patient. So why would the patient be interested in having transport ovarian tissue freezing? She is most likely, she has had a devastating diagnosis posed to her. You have a severe cancer. It may be a potentially deadly disease. Now, are you ready to travel to another hospital to have your fertility preservation performed? You may need to stay there overnight, a lot of stuff. Of course, if she can stay in her local environment, at home, and just go to the hospital for an outpatient procedure to have the ovary taken out, this is a lot more attractive to her. She also may actually be too sick to say, oh yes, I'll travel to Copenhagen, I'll travel to another hospital to have this procedure performed. So if you could do it locally, then of course it is a much more interesting option for the patient. And I mean, if it is a child, and this is the only option we have for fertility preservation in these patients, then the parents needs to do a lot of extra to go with the child and so on, and this is also just complicating things. So from a patient perspective, this is very interesting. If you look at the referral center, then the way it works in Denmark is that the referral center don't have, this is an IVF center. They do IVF treatments all in the remaining time, which is the vast majority of time. So they don't need to consider having SOPs to get everything organized around it. They can concentrate of counseling the patient and saying, this is your options. We'll take the tissue, put on a flight or a car to take it to Copenhagen, and there they will procure it. So this also means that you don't need to allocate additional staff. You don't need them to be educated. And if you don't do it too often, you lose the ability. And then you say, oh, we'll concentrate it on 2 persons. But if these 2 persons then does not happen to be at work when it's needed, you're sort of not doing too well. So there's a lot of benefits from the referral center as well. And if the patient wants the tissue back, it's brought to them, and the operation is performed at the local hospital. The central laboratory, of course, also needs to consider this in detail and get it all organized. But this is a seldom performed procedure. So if you concentrate it on one laboratory, they can actually now specialize in this. And if you look at the centers in Europe, in Brussels and in Denmark, they actually their only clinical procedure is freezing of ovarian tissue, which means that they concentrate. They are looking into developments, they do research, which at this point is mandatory to perform this procedure. And this all goes into the central laboratory, which you then may be able to equip with persons and equipment so they can actually perform these procedures. So I do think that this is a win-win situation in many instances. So how did we evaluate this initially? I just want to put up this paper, which is actually pretty old now. It's more than 20 years. And the interesting part here, and I just want to acknowledge that, is that those people who are on this paper, Erik Ernst, Anne-Grethe Byskov, Anders Nybo Andersen, and myself, we were the ones who established this in Denmark 25 years ago. And the first author is Kirsten Schmidt, who married to be Kirsten Maglund, who was our PhD student at that point and did this study. So we evaluated how well does ovaries, which has been transported, how well do they do? So we had 4 ovaries which were transported on ice from Aarhus 4 to 6 hours, and then they was received in Copenhagen. We had 2 control ovaries from our local hospital, so this is just 5 minutes away. The ovaries were frozen following the slow freezing protocol, as most people do, and as we have used over the years. And then pieces of cortex were transplanted to immune-deficient mice for 4 weeks to assess follicle survival and growth potential. So here's a lot of data, but actually each one of those cases are listed here. So the case 1, 2, 3, and 4 are those which were transported and frozen, and the controls are those which were from our local hospital. And what you see is the number of primordial, primary, and secondary follicles. So we wanted to see whether the developmental potential of these follicles, once we transplanted them to immune-deficient mice, whether these were as good when they were transported as when they were not transported. Because if they responded to sitting in the mouse for 4 weeks by moving to primary and secondary stage, they were still functional and still alive. And if we just look at the primary follicles, you can see in the fresh tissue, it actually turns out that the percentage of primary follicles in the fresh and thawed are pretty similar, but in the transplanted tissue, they do increase significantly, comparable to the control tissue, which means that follicles sitting in tissue that were transported once transplanted to a mouse actually developed with the same speed and the same capacity as those which were frozen immediately, which to us demonstrated that at least those follicles looked as if they were equally good. And this is just the histological sections coming out. You can see here that this is mouse tissue, and here you see human ovarian tissue, and you can see a whole brim of follicles that has survived 4 weeks in the mouse. And if they are present after 4 weeks, they have survived. 4 weeks, if they're dead, they would have been disappeared. So any follicle there is viable. So actually, if we look in bovine tissue, we were taking this up, then if you store this at 20 degrees for 18 hours, then you have a significantly reduced percentage of morphological normal follicles compared to controls. So it is better to store them at cool temperature. And this also reduces the metabolism of the tissue. Then we developed a technique to quantify the survival. Quantitative survival, we use the neutral red staining. This is a substance which has been present since the 50s, and Roger Gosden used this as well. This was where we got the inspiration. The thing is that it is a vital dye. So this means that any follicle which is viable will take up the dye and turn red. So all these follicles that you see here, they are perfectly viable. This one here may not be. This is the substance, and this is when you look at the number of follicles from histology, and then you have counted how many were red in the pieces. You can see a beautiful, significant linear relation. So the viable follicles do turn red. And this is the procedure. You take out 1 or 2 pieces of tissue, you chop them up, and small pieces, incubate them in neutral red. You can see here, you don't come out too well, but there's a lot of small red dots here. You count them, you make histological sections, and then you take the fraction of those which were red compared to the total amount of follicles. So this is the survival rate. If we do that and look at storage time, or we can just looking at it, then we have in fresh tissue, 91% of the follicles are viable. In frozen thawed tissue, 25 pieces, 84%. So a drop in 7%, which basically means that the majority of follicles survive the thawing procedure. And this is just the storage time over time. So this is 2 years, this is 18 years. Same follicle survival. So once it's in liquid nitrogen, forget it. But the beauty is that if you compare transport and no transport, then the survival rate for the primordial follicles are absolutely similar. So you can cool it down, transport it at least for 5 to 6 hours, and then sort it out, and the number of follicles are equally good, okay? So what have we done? We actually now don't put it on a flight. We actually have it on transport. It's accidentally that I found UPS. It could be anyone. I don't want to advertise for UPS. But we have done more than 600 ovaries now with transportation. And we have transplanted more than 80 times, and all with return of ovarian function. So the transportation do not destroy the follicles. And we have had a number of children following this, and this is similar to what we see with fresh tissue. So we do confirm transportation of ovarian tissue is viable. So does it work when we are looking at prepubertal children where the ovaries are transported? The ovaries are not active when we take out the tissue in prepubertal girls, but when we put them back when they are old, they of course are. And what happens when we do that? So we have collected 6 patients here. This one, 14.9, I'm sure Hamish would say that she is not premenopausal. And she is not, of course, but close to. And they had them transplanted when they were in their 20s, and one early on to induce puberty. If we look at the development of how FSH is downregulated upon transplantation, so these ovaries were transported before freezing, then we transplanted them and looked at how FSH and LH is downregulated. And we are looking now at adult, so this is a lot of patients, and this is both fresh and transported tissue, but all the prepubertal are transported. And here in the beginning, we did measurements after 4 and 8 weeks, and we figured out that it didn't mean anything. So we just did this after 12 weeks, and you can see FSH and LH are basically decreasing, being downregulated. Pituitary secretion is downregulated equally well, whether this is tissue from prepubertal girls that has been transported or it's an adult woman. So this again demonstrates that transportation is not deleterious to the tissue. This is just what we published with Michael von Wolf in 2019. The differences between our centers, our local hospital is the black, and the open one is from Jutland. This is 4 to 6 hours of transportation, and you can see we had a drop in connection with COVID, and this is now only slowly recovery. But the majority of tissue is actually transported in our system. So the medium used. Initially, we said, okay, use flushing medium for IVF, because this is Hebes buffered, and we want to maintain pH during transportation. But then we figured out that maybe Hebes medium was temperature dependent, the buffering capacity. And it actually did turn out that Hebes changed pH capacity if you cool it to 0 degrees. So we figured out we needed to change that. And we actually got the inspiration from Germany, and I'm sure that this will now come out in the next lecture. We now switched to custodiol, which is a histidine buffered medium. So this is the medium which is used universally to transport whatever organ. This is always done cold, in fact, heart, liver, lung, and whatnot. But now we also use this for ovarian tissue. And we did a study where we compared the pH. And if you use Hebes buffer, it actually increases. So it actually came up to pretty high levels when it's cooled down. So, but if you use the histidine, the custodiol, it actually maintains beautifully at physiological pH. And this is both the mean and the standard deviation, so it's even more precise. And now the discussion from the last section, session was the number of oocytes. Here we do not see a difference in those ovaries which were transported. It's correct, as was stated, we have differences when we look at different amounts of different sections of our cohort of oocytes. So I will acknowledge that we don't know with this with certainty, and perhaps the capacity to mature to metaphase 2 is slightly reduced in those follicles which are transported. So I just want to lead to the next presentation. So this is prolonged transportation overnight. We did that at one point because the bridge, we had a storm, our bridge between our islands were closed, so the ovary didn't come around until the day after. So we said, let's have a look and then transplant the tissue. We transplanted the tissue to immune-deficient mice for 4 weeks. The insert is how it looked before. 6-year-old girl with rhabdomyosarcoma, lots of follicles. After transplantation for 4 weeks, this is how it looks. And this is so beautiful that this is exactly what happens in an ovary where follicle initiation or follicle growth is initiated. You can actually see a lot of primordial follicles. You can see blood vessels. This is how the ovary works. The follicle secretes angiogenic factors, attract blood vessels, and are now exposed to more FSH and LH, and then they start to grow. So this also happens when the tissue has been transported overnight. So I do think that there's fairly good evidence to suggest that this is a viable option, and I do encourage you to consider that. So in conclusion, and this is the, it's cold in Denmark now, but we do have the sun do come up every now and then it can be pretty beautiful, but it's harsh times. Ovarian cryopreservation, including transportation, is now clinically well documented. Transportation of ovarian tissue is feasible with similar efficacy as immediate freezing. Transport temperature should be around 0 degrees and may last up to 20 hours, but I'm sure next presentation will allude on that. It should be a histidine-based buffered media, which you should use for transportation, but then when you cool it down, the metabolic rate of the cells are low, and it probably doesn't mean too much how the composition is. And surprisingly, and I think that is worthwhile investigating, the oocyte, even cooled off to 0 degree, remain the capacity to sustain metaphase 2 transition, which is new to human oocytes. So I thank you for your attention.
Thank you very much, Klaus. We move to the second speaker, Jana Liebenslom, please. And I introduce a short. She is an expert in embryology and qualified reproductive biologist. She is the vice chairwoman of the Fertility Protect Network Association and members, consultant, and official co-operator of the Fertility Protection Project, FPP, at Beijing Obstetrics and Gynecology Hospital, Capital Medical University in Beijing. Thank you. Please start your lecture.
Thank you very much. Thank you very much for the kind introduction, and thank you very much for the organization committee for inviting me and for the opportunity to present our study, our results about the transportation of Ovarian tissue. Thank you very much for the good words at the beginning, because we are sitting in the same boat. We have the same issue. We have a lot of clinics in Germany who remove the tissue by a laparoscopic surgery for cryopreservation of ovarian tissue, but the clinics have not the opportunity to freeze the tissue on site, and that's the reason why we thought about opportunities and why we transport the ovarian tissue through Germany for cryopreservation. The cryopreservation process in general, and also the transplantation, is an established and accepted technique in the meanwhile. We have described over 250 live births in the theory, and it is of course possible to transport the tissue after the laparoscopic removal to specialized centers, in our case to centralized cryobanks in Germany, for a standardized and high quality cryopreserving process. However, the transport of ovarian tissue is not a simple process. You have to think to a lot of points, but it remains a key, or it remains at a key focus for us, especially through the increasing numbers of ovarian tissue over the years. You can see here the development of the numbers of the FertiProtect network, and in total we have freeze 5,269 tissues, and per year it is around 310 tissue pieces. The ovary itself is a complex organ with different cell types and structures with different needs, and it's absolutely important to choose the right medium for transportation. And medium which is currently used and which I found in the literature is, for example, these alpha-mem medium, Leibowitz medium, Heppes medium, follicle flushing medium, an IVM medium, and the custodiol. And for which medium, or for every medium, it is important to minimize the tissue damage during the transport, and that we have a stable temperature conditions and also a physiological level of the pH at around 7.3. If you look to the literature, which studies were performed in the past with human tissue, then you will see there's not a lot. The first study was in 2009, and ovarian tissue pieces were directly cultured after 26 hours of transport in Brahma 1, and the results were that no evidence for morphological damage were found. Then in 2013, the transportation in Leibowitz medium was investigated after 18 hours at also 4 degrees. These tissue pieces were vitrified before they were warmed again and then cultured, but also this group found no difference in follicle morphology and in the oxygen consumption compared to the fresh controls. And then another study in 2014, in the study the ovarian tissue was transported in Celsius medium for 24 or 48 hours at 4 degrees. And also this tissue were vitrified and then warmed and then cultured for 18 days. And these tissue pieces showed increased malondialdehyde concentrations, which is indicating for oxidative stress and later auch apoptosis in the cells. But the proportion of apoptotic follicles was not significantly different in comparison to the not transported tissue. That means all these studies shown that the transportation of ovarian tissue is possible, at 4 degrees and for a maximum of 24 hours. But the most of these media is currently not used in the clinical practice. So what is the most challenge in the time of the transportation of the ovarian tissue? It's the ischemia process. And the ischemia process begins directly after the ovarian tissue is removed by the surgical laparoscopy. And the consequence of this is that in these cells, acidosis and energy deficiency begins. And these cells formate radicals and the oxidative stress levels increase. And the consequence of this is apoptosis in the follicle cells and in the oocytes. And this ischemia process stops if the tissue is after cryopreservation and after transplantation around 5 to 7 days after the transplantation and if the neovascularization starts. The cells, we know, have a natural tolerance to this ischemia, but it requires strategies to protect the cells for a longer transportation time. And a possible solution, which we find, is custodiol. We have very good results after the transport with custodiol. And this is a solution which is initially formulated to protect organs from ischemia during the transport, like hearts, livers, kidneys, but there are no any experience before with ovarian tissue. And I asked the company what is inside and what is so helpful. And they give me this slide, thank you. And there are a lot of compounds inside which are solved in an intracellular solution, which stable the cells between the transport, which reduce the oxygen consumption, which stabilize the cells, and apoptosis mechanisms are decreased. And it's an isotonic medium, and the consequence of this is that the cell swelling and oedema formation is decreased. And it's a powerful combination of conserving the energy, and it's a good buffer against these cellular acidosis. We use custodiol since 2010, and we can make we made the first evaluation of our numbers with custodiol. We evaluate our system, and our system is this. We have these blue boxes with these cooling packs, and these are 3 pair of cooling packs. We store these cooling packs before in the fridge at 2 to 4 degrees. We have here a temperature scale inside, and we have also this small chip inside. That means we can check during the whole transport the temperature. And we transport our medium and our tissue in the middle pair of these cool packs. And the clinics remove the tissue. They order the boxes before, and then they send us the tissue via overnight, maximum 24 hours. We have in Germany 3 centralized institutions for cryopreservation of ovarian tissue. And after arrival of the tissue, we directly prepare and cryopreserve the tissue again under controlled conditions. We have here this cooling plate, and we prepare at 4 degrees directly. And we looked for our results after the transplantation of ovarian tissue with tissue which was transported before. And you see that we include in the study 62 patients with 78 transplantations. And you can see here the rate for the tissue activity, clinical pregnancy rate, and the delivery rate. And then in comparison, the group in this 30 patients with 30 transplantations, and this group get tissue back which was transported in the time before. And if you compare the results between the whole group and the group which get the tissue after transportation, then you can see we have no negative impact. We have a little bit better results. After that, we were interested, these were our own numbers from Bonn, and then we were interested how are the success rates in the whole network, in our Fatty Protect network. And then we evaluate the numbers from 2007 to 2019. We conducted 247 transplantations, and you can see here again all transplantations which we performed with 200 patients, and then in the second line 227 transplantations from 101 patients with tissue after overnight transportation. So the mean age is the same, and also the storage time. And here are the results. In orange, you can see the results of all patients for the endocrine activity, pregnancy rate, and live birth rate. And in blue, you can see the results with tissue after overnight transportation. And also here, we have no negative impact. We have a little bit better results with tissue which was transported before cryopreservation. Here are the numbers of our live birth until 2009, 47 babies, healthy babies, which are born. And these are our current numbers until 2022 in the network. We performed 410 transplantations, and you can see here the results are equal. Now we have documented 71 babies, but in this evaluation we have not the differentiation between the group with transportation and the group without transportation. Then I moved in 2018 to a new center to Düsseldorf, and we start there with the same process like in Bonn, the cryopreservation of ovarian tissue. And we performed in this time from 2018 to now 54 transplantations in 45 patients. And we have our pregnancy rates, you can see here, and the delivery rate. And our pregnancies are in 70.6% on the spontaneous way, and only after transplantation in the peritoneum. Here you see the overall rate from 31.5% pregnancy rate of all patients, and 25.9% is the delivery rate. And here we have also these both groups, which we compared, the group without transportation of the tissue before cryopreservation, and here is the group where we transported the tissue. And if you compare the numbers, the pregnancy rate we have here 34.2% in comparison to 25, and here 28.9 in comparison to 18.8. That means we have also no negative impact. These are the same results, but again, we have a little bit better rates after transportation of the ovarian tissue. And here, these support the results from our previous study and also from the evaluation from the Fatty Protect network. So we looked further to the literature, and we thought a study in this talk before. This study support our results. Klaus Eding Andersen, they compared also the transportation of ovarian tissue in herpes buffer in an IVF medium and in custodiol for only 4 to 5 hours at 0 degrees. They isolate image oocytes. They performed the IVM, and then they looked for the maturation rates. We have no data about the fertilization rates, pregnancy rates, or live birth rates, and we have also no results after tissue transplantation. But what they could show was that the pH level was more stable than in the IVF medium, and the maturation rates were a little bit better after transportation in custodial medium. So that supports, therefore, our results. Then this study from the Chinese group, they have the identical transport logistic like our center. They use also the identical freezing protocol and the identical thawing protocol. They built 3 groups. The first group was the tissue was investigated immediately after the removal. Then the second group was directly freeze after the removal without transportation, and the third group was after 24 transport in custodial and then cryopreserved and later thawed. And they prepared 2 millimeter biopsies, and they performed a lot of investigations. And the result was that it was a small study, only 9 patients were included, but also in this study, the results showed no significant differences between these 3 study groups and support our results. So we are surprised for the results after the transportation in custodial, and we are interested what has happened with the tissue, so why we get a little bit better results, what is the consequence after the transportation in custodial especially. And we start also a small study with 14 patients, only with the same diagnosis, and we use our standard logistic. And we performed mRNA analysis for the whole genome, and we performed different statistical evaluations. And after these FDR, we saw that only 5 genes were upregulated, and only 11 genes from the whole genome analysis were downregulated after the transportation in custodial. And in the future, we need more data, we need more patients, and maybe, our big question is what is the reason that custodial is performing better than, or why is it better to transport the tissue in comparison to not transport the tissue? So at the moment, we do not have an answer. Maybe you have an answer. Then I'm coming to the end. Important is for the transportation that we have a protocol, maybe that we have a guideline for it, that every patient gets the same conditions. For the future, it's important that we better understand the ovarian metabolic function of each cell, and how we can protect this cell. We do not have only the ovarian cells with the oocyte, we have also the stroma tissue, and the stroma tissue is important that later the follicle cells can grow up. The question is, need we any antioxidants or other protective agents in the media to get maybe better results? So the big goal should be that we optimize our method. And maybe is it better to use for the future to change our freezing method and also the thawing procedure. At the moment, all our results are after the slow freezing process. And we should to minimize extensive the follicle loss and the ischemic cell damage through the whole process of cryopreservation, transportation, cryopreservation, thawing, and the first days after transplantation of the Ovarian tissue. Thank you very much.
Thank you very much, Jana.
Okay, we have to have the last speaker. It's agreed pleasure for me to introduce the talk of my co-chairman. Dr. Kiyono works in IVF clinics in Morioka, Sendai, and Tokyo. And he has a Center for Fertility Preservation in Tokyo. He succeeded in the first birth following frozen to oocyte by slow freezing in Japan in 2001. Thank you.
Thank you. Nice introduction. I have no COI. Contents. First, characteristics in Japan. A declining birth rate and aging population in Japan. Especially the population of under 35 will remarkably decrease from now on. Low birth rate aging society in Japan, the population of women under 35 years of age, the target age for fertility preservation is declining. The number of doctors, nurses, and embryologists is decreasing. The number of hospitals is decreasing. Population will be concentrated in centers. Hospitals will be centralized, and OTC/OTT centers will also need to be centralized. Natural disaster in Japan. Earthquake, typhoon, heavy rain, landslides, and flooding are popular. We experienced the Great East Japan earthquake, tsunami, and nuclear power plant accident in 2011. Second, current situation of OTC/OTT. Introduction of cancer hospitals in Japan. Around 480 designated cancer centers and 47 prefectures in Japan. However, most cancer centers have no equipment or OTC experts. We have 46 OTC facilities registered in Japan. However, actually freezing was performed in around 20 facilities. Only 7 centers have experiences more than 30 OTC cases. Number of OTC since 2006. Kanto area and Kansai area. Kanto and Kansai populous areas have any OTCs. Number of OTC/OTT births in Japan. Number of OTC around 500. Number of OTT around 30. Number of births several. As you know, the numbers births following OTC/OTT all over the world. The first live birth in Belgium in 2004. And the first live birth in Fat Protect 2012. A remarkable increase of OTT in Denmark 2013. And then the number of births remarkably increased. A transplantation of cryopreserved ovarian tissue in a series of 2,085 women by the dormants, Belgium 29, Spain 53, France 53, Denmark 62, Fat Protect 88. Denmark and Fat Protect 2 centers occupied more than 50%. The Danish model for fertility preservation, the woman states that tissue moves. Remove one ovary in 4 centers, Aarhus, Odense, Malmö, and Copenhagen. Cryopreservation was performed in only Copenhagen. Transplantation, Copenhagen, and Aarhus. This slide shows the Fat Protect network. According to the lots, maybe the 15 facilities for OTT up to September 2015. Now, the Bonn and Düsseldorf and Erlangen are main OTC/OTT centers. The first success birth in Fat Protect. She is 25 years old with Hodgkin lymphoma. She lives in Dresden, East area. She removed ovary in Dresden 2007. Her ovary was removed in Dresden and then transport overnight to Bonn. The ovarian tissue was cryopreserved in Bonn. And after 4 years, frozen ovary were transported to Erlangen for transportation. The patient underwent the OTT in Dresden, Erlangen, and she came back to Dresden. And after 9 months after OTT, she became natural pregnancy and birth. Comparison of number of population and OTC/OTT. Denmark, in 2020, around 1,200, OTT 120, births more than 25. Fat Protect, population of 100 million, OTC more than 4,000, OTT more than 250, births more than 50. Japan, population 126 million, OTC number around 500, OTT 30, and births several. The aim and outlook of hope. Aim, anyone can do ovarian tissue cryopreservation no matter where they live in Japan. Hope was established in 2016 and moved to current location in 2020. 45 OTC cases by slow freezing with transport system. OTT was not performed yet. This is the basic study of our clinics. In 2014, we compared between transport 6-hour flight and 18 hours transport by carrier service. And from Sendai to, from Osaka to Sendai transport using live beats medium at 4 degrees centigrade. The results strongly suggest prolonged transportation of ovarian tissue at low temperature is useful. A second basic study in 2017, a transportation network for human ovarian tissue is indispensable to successful fertility preservation. Survey results in OTC/OTT in 2016. At that time, the maybe 10 centers could have preserved ovarian tissue. This slide shows the cost established maintenance of one cryopreservation center for 30 years. It costs maybe very expensive. So economically, decentralization is more expensive. The Danish model, the women stays, the tissue moves, is truly patient-centered medicine. We can achieve a maximum benefit with minimal burden. A transportation network like those of Denmark and Germany is the best strategy for FP in Japan. Characteristic in hope, telemedicine, transportation, and 1 to 24 hours, the highest quality and safest techniques by experts, slow freezing, regular training, using the cow, bovine ovaries every month, and new information, support sowing and transplantation. Our disaster countermeasures. First, built a new hope on the solid land, 20 meters above sea level. Designed for easy evacuation, the cryo storage tanks were located on first floor or on the ground floor. If we experience the fire, we push out the heavy liquid nitrogen tank to the outside. As you know, the liquid nitrogen tank accident occurred in San Francisco, Cleveland, and Toronto in 2018. So, as a risk management, ovarian tissue is stored in 2 liquid nitrogen tanks. Convenience location, 30 minutes drive from Haneda Airport, 5 minutes drive from Shinagawa Station. O2 sensor in sensor 1 meter above floor, alarm 20 centimeter below ceiling. Liquid nitrogen tank monitoring used liquid phase type in Japan. Manual measurement liquid nitrogen level 1 to 2 times per week. Installation thermometers outside the tank. Installation of a tank weight scale. OTC networks. Case 1, by airplane specialized carrier, Itami Airport, Osaka to Haneda Airport. The overnight stay at the airport, we arrange the transport to Hope by car at 9 o'clock a.m. It takes for 18 hours. Case 2, by Shinkansen, Hope stop or partners of family transport. From Iwate Prefecture to Tokyo, around more than 2 to 3 hours. Transported to Hope by car, total, it takes 4 hours. Another case from Shiga Prefecture. From Nagoya Station to Shinagawa Station, it takes 1.5 hours. Transported to Hope by car, total for 5 hours. Case 3, we experienced 40 or 45 cases. In case of within 1 hour, the patient's family or Hope staff transports the ovary. I'd like to discuss food transport of ovarian tissue in last discussion. Building a collaborative network. You are here in Tokyo Station. Our Hope is from here. It takes about 40 minutes. Collaborative network in Tokyo Metropolitan. In 40 cases we experienced. There are 2 cases. One is they can cancer treatment only, and they do not remove ovary. In this time, we request to endoscopic facility to remove ovary and transport to Hope and cryopreserve. Another type, they can do cancer treatment and tissue removal. In that case, we transport from directly to Hope and cryopreserve. Transportation box arrives at Hope at 9 o'clock a.m. Next day. We arrange. We use a transportation box from Fat Protect. Ovarian tissue in preservation medium. Now we use custodial iceberg on 4 degrees centigrade. Temperature during the transportation using Dana logger. We monitor the temperature inside of the box. Transportation method. Private transport by family, private transport by staff, transport by company. Recently, we experienced ex vivo oocytes retrieval. Considering the risk of ovarian metastasis in a patient with cervical cancer by oncologist, controlled ovarian stimulation and hope using PPOS. Second, removal of stimulated ovary in cancer hospitals. Transportation from cancer hospitals to hope at 33 to 36 degrees centigrade within 60 minutes. Oocyte retrieval from removed ovary in hope. Women with cervical cancer, age 31, AMH level 4.86, 86 nanogram per ml, ex vivo oocyte retrieval on September 6. Transport 33 to 36 degrees. It was returned the same day by medical staff to the doctor sent ovaries for pathology examination. We could the 6 metaphase 2 oocytes, and after 2 days, we could have preserved by vitrification 5 cell, 3 embryos. Ovarian tissue cryopreservation and hope. I learned about ovarian tissue cryopreservation for the first time in Sydney, IVF. So we continue to study and clinical job. Now we can do only 45 cryopreservation by throat freezing. Continuity, succession, and cooperation, passing on to people with management skills and foresight like Adachi Hospital, Kyoto, Japan, or Mayo Clinic, Rochester, Minnesota, USA, has a history of 100 years. Also, we need to cooperate with other OTC centers for natural disasters. Conclusion. This model has been termed the Danish model. The woman stays, the tissue moves. This is truly patient-centered medicine. We can have maximum benefit with minimum burden. A transportation network like those Denmark and Fertility is the best strategy for fertility preservation in Japan. It may be the best system for cancer patients, medical staff, and Ministry of Health, Labor, Welfare. I would like to express the deepest appreciation to Professor Nao Suzuki and his colleague at St. Mariana University School of Medicine. Thank you for your attention.
Thank you very much for this very interesting presentation. Thank you to all the authors, because the ovarian tissue transportation is a very important aspect of program of ovarian tissue cryopreservation. I don't know, you can go to...
Hello, Marie-Madeleine Dolmans from Brussels. Does it work?
Okay.
So thank you for your nice lecture on transportation of the tissue. So we have good examples indeed. I wrote an email 2 days ago to Jana because a patient in Essen in Deutschland, Germany, was about to have ovarian tissue cryopreservation, but the hospital was not in the list of the admitted hospitals with whom we collaborate. And so she will have the surgery for her cancer, but we don't know what to do and where to send the ovarian tissue in Germany. So I would like to insist, especially for the Japanese team, that once administrative burden comes up into our clinics, it becomes really difficult to counteract and to do a patient-centered medicine. So this is the problem when the hospital is not in the list that is admitted by the administration. Although the hospital is at a few kilometers of her well-known center, she is not allowed to take it. Correct, huh? We have the same, in fact. I don't know in Denmark how it is, and I don't know how it is and will become in Japan, but be careful. Klaus, is it the same in Denmark? If where the ovary comes from, if it's not in a center that is allowed?
I'm trying to turn it on. Now I succeeded. No, in Denmark, you know, we are obliged to follow the EU tissue directive. And when we are inspected, we need a close agreement with the centers which send us the tissue. And if it is a hospital in which we have an agreement and they need to follow the EU tissue directive, we are unable to receive it. So that's the same thing, but you need to establish those collaborations. And if you didn't just have a hospital say, oh, we have taken out an ovary, what do we do with it? They should actually have asked before that.
How long does it take to have that agreement? We can have it sometimes in 2-3 days.
This is a really complicated process.
You see?
Yeah. So
anything administrative is not easy, huh?
And this was an absolute special case. Normally, it's not a problem because normally our patients get a cancellation and then they get the information which clinic is allowed to remove the tissue. In this case, the patient was in a clinic and this clinic was not registered and the time was too short.
So it's important where you have the oncological surgeons with all these hospitals to have if you use it or not, a legitimate document for the collaboration.
But we have our Ferti Protect network, and this inform every clinic, and every clinic can be a part of Ferti Protect. So Essen, in this case, was not a part, and but this is not. So, yeah.
I'm Okunomiya from Kyoto University, Japan. I have a question to all the speakers. Do you find any difference in practice when trimming ovarian tissues between ovaries with no transportation or with after long transportation? I mean, for example, probably the ovarian tissue after long transportation gets softer, so that we need to pay more attention not to damage the ovarian cortex or whatever.
Yeah, no, I would be happy to answer that. No, we don't see any difference. The tissue do not become softer after transportation. This is pretty similar, but you know, ovarian tissue differ quite a lot. So you can have tissue which is very rubber-like and very difficult to prepare, but this is independent on whether this has been transported or not. But of course, human ovaries differ tremendously in their texture, but no transportation effect.
Yeah, we have the same experience, so the quality is equal. Sometimes if you have a corpus luteum inside, maybe then in this area the cortex could be different, but that's not a problem of the transportation, so it's a problem of the ovarian cortex.
That's correct. The corpus luteum obviously is an area of the ovary where you have had a burst and an ovulation, and then that part of the cortex is not easily prepared. So we usually advise the surgeons that if they have an option of 2 ovaries, take the one without a corpus luteum if that's an option.
Yeah.
Okay, thank you.
Hi, Deborah Gook from Australia. Dr. Kono and also the other speakers, I was super pleased to see you brought up the whole issue of a disaster and what would we do in a disaster. I'd like to ask, do you separate your vials into your two tanks that you have in case you have a failure in one of the tanks? And then from the other speakers, have they also thought about, these patients are going to have tissue for many, many years, and have the labs looked at a contingency plan for a disaster?
We always use two tanks. We always have two tanks in two separate rooms in our basement, so they are pretty far apart. And then, so half of the tissue goes into one tank and the other half goes into another tank in case of a disaster. We don't have a lot of sort of big disasters with earthquakes and so on in Denmark. So we actually don't have any contingency plan on top of of dividing it.
We divide also the tissue. We have our tissue outside in another cryobank, and they divide the tissue of two tanks.
I would like to comment. I'm Kenny Rodriguez-Wahlberg from the Karolinska Hospital in Stockholm. Thank you very much for your presentations. You have really convinced with also your research and your papers. In Sweden, we are starting to organize centralization of cryopreservation of ovarian tissue. We are only 10 million inhabitants, but Sweden is a big country, so distances are long. We have discovered a benefit of centralizing, and is that when the tissue is transported in the way you described, the tissue comes to the embryology lab 8 in the morning, and the embryologists start working with the tissue they knew from the day before. And this is an easy work organized this way. It's not the same when you get the tissue at 5 p.m. and the embryologists need to work hours during the night, because also it's very expensive for our hospital. So thank you very much for your research.
Thank you. Good comment.
Hi, Glenn Chapman, Cornell. In terms of counseling, is there a specific person in each of these centers that takes the tissue out, that counsels, or are you doing the counseling of these patients in terms of use of the tissue in the future, outcomes, those types of questions?
That's a good question. No, at least for our case, there is local doctors who have an interest in fertility preservation and have studied that, and they're counseling the patient. And they are sort of the ones who organize it. They phone us and saying, can you take it tomorrow? When are you ready? And then everybody needs sort of to be flexible to make sure that this will happen.
In Germany, it's the same situation. Thank you.
Thank you, Pasquale Patrizio, University of Miami, Florida. Have you had any request to have ovarian tissue for post-mortem, posthumous, even with the consent of the spouse, if present or not? I mean, we do have a male post-mortem sperm freezing or recovery, but have you ever had any request for spouse that have died, and you have now this transport mechanism that you can utilize, and if yes, what type of ethical permission you need to have?
No, we do not. That's pretty straightforward. Both of those who want, they need to be alive and signing an agreement on they want the tissue back, and then it's the woman's decision on what she wants to use it for. But we have had no where the woman has died or no, that's not allowed at Danish.
Even for male in Denmark?
Yeah, no, this is not allowed for Danish. This is not allowed.
What about in Germany?
In our country, it's the same. So it's not allowed. And if the patient is died, then we cancel the cryodepot. And
what about in Japan? You can do it? No, you cannot do it. No?
Yes, please.
Now, I'm Yasushi Takai from the president of JSFP as a representative of Japan, and posthumous reproduction is not prohibited. But it is prohibited, not prohibited by law, but anyway, that under the, we don't do that same thing, don't do the thing. And now we're discussing only.
How is it in Miami? Is it allowed?
No, in the United States. No, it's allowed, for example, to take sperm from deceased male, and now they are starting to say, well, if it's possible to get some sperm, and now with all this improvement in ovarian tissue and possibility of extracting eggs from the cortex, why is it not possible that you can take my deceased wife's eggs? So, and that's now is becoming a matter of heavy ethical discussion, right? So, but if it's possible for male, why is it not possible for well, but then you need the surrogate that is going to carry a pregnancy and all the rest of the complications that are with that. But it's a discussion. That's why I was asking if you have any experience.
Maybe from the technical side, please correct me, it's not possible because it's an organ, or it's like an organ, and if you transplant this tissue to another...
I wouldn't be quite sure. I actually think if you do it fast, you could probably figure that out. I think you could, actually. I'm not sure that this would be impossible. But I don't know that.
Thank you very much. Budi from Indonesia. So any data regarding the cost-effectiveness analysis, we comparing the decentralization system with ovarian tissue transportations? As the Koichi mentioned that this system is less expensive compared to decentralization.
Well, I guess that this is just a matter of staffing and equipment. If you have one sensor, you don't need to staff a lot of different sensors with a lot of different equipment. You can just have one lab. And then, of course, this overall, if you calculate the overall expenses for the procedures per case, will be cheaper.
Okay. Thank you.
The post-mortem sperm or ovary is not allowed for cryopreservation, but the real case is a young couple, car accident, okay, and they're married, no child, and this patient is in deep coma. What are you going to do? Is allowed to do ovarian cryopreservation? Young couple, married, without kids, without children.
Yes.
Car accident, so the wife is in deep coma, vegetarian.
In coma.
Yeah.
No, that is not. She needs to be able to sign. And say, I'm interested. This is my signature. Yeah. So you can't do that.
Okay, agree. Second question goes to Dr. Kyono. How about to prevent earthquake if your tank? Because Taiwan, Japan is in the zone of the earthquake very frequently. So how do you prevent if you are ovarian tissue in your laboratory?
For preventing the liquid nitrogen tank? You mean?
Earthquake.
Earthquake. Yes, and whale, you know, the bottom of the whale, they can move, easy to move. And
first floor, right? You
just fixed to the chain.
So what is your preventive measure to try to preserve your tissue? You put the first floor within 30 minutes, you can transport from the room outside?
If we have the fire, after fire occurred, we move to the liquid nitrogen to the outside. We can do.
Thank you.
Can I make a comment?
Sorry.
Can I make a comment? So you, in your presentation, alluded to, and that's actually the first time I've seen this data, that it appears that when you have transported the tissue, it actually comes out a little bit better. And that's a little weird, but I actually think Jacques, at one point after the dinner, gave me a suggestion, which I think is not completely off the mark, actually. Because if you look at it, then you have all these cells in the tissue which are mitotically active. So they're in the process of dividing. And they're, at that stage, they are much more vulnerable to freezing. But if you cool them down, they just sort of finish off their mitosis, and then they don't go any further. So you have probably less cells in mitosis, which means they're less vulnerable to freezing. So this may be something that you get without even knowing it, that you cool it off, and then the cells just sort of, oh, okay, we finished whatever but they don't continue. So it could be that that actually was a reason for a slightly better survival.
Yes, maybe to close the session. Dr. Kiono, you said who is responsible for the transport of the tissue? Someone from the family or an organization? How is it? Because this is not regulated yet.
Regulation is not, we don't have a regulation. But
in Japan, who is doing?
In our hope, I can talk. Within 1 hour, our staff transport.
Your staff?
Yes, our staff.
In Germany?
In Germany, each clinic had a contract with a company.
An official company that is allowed to do the transport of frozen tissue.
Yeah.
Klaus?
Yes, no, this is also the case for us, basically.
Yes, in Belgium also, we have to have a contract with an official company, and that's it. I believe if the patient takes the tissue, it's a good option also, but then you need to provide the transporter also. But from the legal point of view, in Europe, apparently, it's an official company. Thank you.
Thank you. Oh, it's that's right. Okay, thank you. It's finished. Thank you very much for your presentation and for the question.
Thank you. This concludes the session. For those who are joining the seminar in this room for lunch, please exit through the 2 center doors. Then the lunch boxes are set up to your left. Please pick up your lunchbox in the luncheon seminar room you plan to attend. The luncheon seminar begins at 1 p.m. For those who wish to join for lunch, please go outside the room first and take a left. Lunch boxes are set up to your left. Thank you.